you'll notice with question 4, you got a pile of information there. And that information was necessary to answer that question. Here's another thing about the AEMCA, though. As you are fed information throughout the questions, that information now becomes information you know and could come up in subsequent questions. So that behavior in question 4 and the behavior from earlier in the scenario all are starting to paint a picture as to what is going on with this guy. If you were to be asked a differential diagnosis on this patient after the question number 1, it would be kind of a dumb question because there would be no way to have any idea what's going on with even the slightest degree of certainty. But the picture starts to paint itself as you keep going. So after question 4 is question 5. You and your partner respond appropriately. Patient behavior changes drastically. Cool. Patient now appears very scared, timid, and shy. Okay. Patient is now speaking. That's good. Patient is oriented to time, place, and name. That's really good. Patient is confused as to why he is in an ambulance. I bet. That's all really interesting. And we're going to talk about that in a second. So basically, he has had a completely different presentation now of his level of awareness. It has gone from a GCS of 3 all the way to a GCS of 15. Patient last remembers going to work. That's pretty crazy because a lot of stuff has clearly happened since then. Patient denies any medical history. Okay, that doesn't help us. Patient denies drug or alcohol use. That's useful. You find patient is a 34-year-old male. Okay, cool. Patient has no complaints of pain. No complaints of pain. That's really an important finding. Patient states he just feels off. That's a better finding than you would think. You and your partner have been discussing this entire call what could be the cause of this patient's symptoms, which you would be because it's a confusing situation. But now that this happened, you are now fairly certain that the most likely reason for this patient's altered level of consciousness is the following. Okay, this is a differential diagnosis question, and it should come up with every single scenario on the entire AEMCA. At some point, they're going to say, what's wrong with this guy? And you're going to have to decide what is wrong with this person. And that will be based on the information within the scenario. So let's just, before we even make a decision, find things that are worth entertaining. So, A, patient has had a syncopal episode prior to the arrival of paramedics. Okay, at a glance, you might think that's a really good option. And sure, let's entertain it. There's a couple of reasons why that is not that great of an option. We'll explore it. Patient has a severe traumatic brain injury following assault. Well, there's a couple of things in this statement. First of all, severe traumatic brain injury. Severe traumatic brain injuries tend to be associated with a GCS of 3. Now, we know this guy at some point was a GCS of 3 based on the bystander, but he's certainly not a GCS of 3 right now. So that just doesn't make sense. If you have a severe traumatic brain injury, severe meaning causing GCS 3, you don't just wake up oriented following that. That's completely impossible, or it is a complete indication that it is not a traumatic brain injury. So let's just go ahead and delete that. Patient is post-ictal following a seizure. That should have been on your mind since the beginning. You may not see why, and we'll talk about it in a second, but it's certainly worth entertaining. Patient is hypoglycemic. That, at a glance, you're going to think is worth entertaining. Some people thought that was the problem. Okay. So let's entertain it, because I could see why you would. You'll see why that's actually not even worth entertaining in a second. Patient has multi-system trauma. Well, he certainly has no physical indications of that, right? And it says right here he has no pain. It's pretty hard to have multi-system trauma and not have pain. Probably a complete impossibility. So let's go ahead and let's entertain it, just for fun. Okay? So we really only got rid of one thing so far, which is B. You wouldn't want to make this decision without going back through the entire scenario. We're just going to do a quick version of that. So let's look at the information we have. Okay? basically, we have two different GCSs even within this initial scenario information. We have the GCS from the bystander, right? That's really important information now. Now it is. His eyes were closed, right? He was unable to wake the patient after shaking him. So he was a GCS 3, this dude, on arrival. Okay, 3, not good, worst case scenario. Then when you arrived, he was already a GCS 9. We already know that, we calculated it. And then he went through like a violent agitated state, right? We already know that from question 4. And then following that, he went right up to a GCS 15. Maybe 14 because he said he feels off and stuff, but he was oriented to time and place and name. So technically he's a GCS 15. This is a really important trend. His GCS went from 3 to 9 to 15. Also, another piece of information here, he's incontinent of urine, right? Incontinent of urine could mean many things, but it's often associated with seizure. It doesn't have to just be seizure, but it's pretty heavily associated with seizure. Okay, so cool. Let's look at the options again now that we have that fresh in our head. A syncopal episode tends to be a temporary loss of consciousness, and then consciousness is restored. You do not wake up from a syncope with a GCS of 9. If you do, you didn't have a syncope. Almost certainly, because a syncope is really just a transient loss in blood pressure. The blood pressure drops, you fall to the ground, your blood pressure comes back, and now that was a syncope. What was the cause of a syncope? Well, that's not easy, but that's not what we're talking about. The fact is, this guy went from GCS 3, 9 to 15. That really doesn't line up with a syncope at all. Also, if you want to get even more into it, none of his vital signs show any indication that he had a syncopal episode. He should have been tachycardic or low blood pressure or something, and he had nothing like that. So let's get rid of that. We already got rid of severe TBI. Now let's entertain these two. Patient is postictal following a seizure. That's a great answer. Let's keep that. Patient is hypoglycemic. You may still think that's a great answer, but remember, his GCS went from 3 to 9 to 15. Think about it. Think about your patho. Do you think his blood sugar just got better? Went from 2.0 to 3.8 to like 9? That doesn't make any sense whatsoever at all. If his blood sugar was 2 and that was the reason for all of this stuff, then it shouldn't just spontaneously fix itself. It doesn't make any sense at all. And if it did, it shouldn't be slowly over time, just this gradual increase in glucose. Knowing your diabetes pathophysiology should tell you that. The way that we think, it definitely is the first thing you think, oh, hypoglycemia. And it should be the first thing you think, and it should be the first thing you check. But it really shouldn't be the answer given the information we have. Patient has multi-system trauma. We probably could have got rid of that before. But now I would really say to get rid of it because none of his initial vital signs supported it at all. And his GCS, again, should not just get better. We didn't do anything to this guy. We gave him no treatment. We did nothing for him. Well, maybe some oxygen in an airway, but that's it. And just from process of elimination, we're left with C, which is the answer. Patient is post-ictal following a seizure. A couple of key points about the AEMCA with this question. You needed to use information from many questions to make this decision. You needed information from 3 questions, tons and tons of paragraphs worth of information to make this decision. If you were wrong about this decision right now, question 5, you will probably get many questions wrong following question 5 because they're all based on you knowing what's wrong with this patient. You'll see what I mean as we move forward. Question number 6. This may seem like a simple question, but it's actually quite complex. 1, it builds on all the information you've already acquired. 2, if you're wrong on previous questions, you are going to be wrong on this question. There's nothing you can do about it. And 3, it's kind of a complicated way to ask you again what his differential diagnosis is. So we already asked you the differential and you answered it. Now I'm saying, what is the most likely emergency to occur as a result of you knowing that that's his differential? And how would you prepare for it? The emergency, of course, is another seizure, right? If you had a seizure, then you may have another seizure. If you've never had seizures in the past, and this is your first seizure, it's safe to assume that some type of emergency is causing it that will likely make it happen again and again. Not for sure, but that's the most likely emergency. So let's look at these options and see how it could have totally tripped you up. Prepare an IV for a fluid bolus. This supports the trauma narrative. But again, there's nothing else that supports the trauma narrative. However, this option is here in case you got mixed up, picked the wrong answer, and now you can pick the wrong answer again. Pretty rough stuff, I know. But this is how you end up with like 5 or 6 questions wrong in a row, and that's why you have to spend so much time on your differential diagnosis. Preparing an infusion of dextrose 10%. Okay, so if you thought hypoglycemia was the answer, you'd pick B. Here's a very important piece of information regarding AEMCA tests. Don't ever assume anything at all. You can't put information into the exam. Nobody told you this guy was hypoglycemic at all. Yeah, you took a blood sugar. It's on purpose that I didn't tell you the guy's blood sugar. So now you think, oh, he could be hypoglycemic. He never told me he wasn't. Doesn't matter. If you don't know, you don't know. This is saying I'm going to prepare to give this guy dextrose. That's a crazy thing to do without any information to support that he's hypoglycemic. Right? So that immediately deletes B and C. Why then does it say dextrose 10% followed by dextrose 50%? Just to make it more difficult. When you see those two dextrose together, that makes you think, oh, I bet you they're trying to trick me by putting 50% here. Well, I know that the protocol says to give 10%, so I bet you the answer is B. Who cares? No, it's not B. It's not hypoglycemia. That's just another trick. Prepare airway equipment and BVM, or place defib pads on patient. Well, this comes down to what's going to kill somebody if they have a seizure, and it's airway complications. So the answer is D. You won't have a seizure and just go into VFib. Well, anything is possible, but that's not the likely outcome. So the answer is D.